Dr. Amr. Professor Jangali had made my job very easy because he told us after compression we have fibrous and fat tissue. We don't have any more any fluid. And we have this problem. And I cannot make a nomenclature. Is it fibrosuction or lipolymphosuction? The problem is old. Even lipedema here. This is in Hatshepsut temple, and this picture is called the lady and the donkey. The conservative management in the form of massage or compression, and this is a book about 10,000 year history of medical support bandaging. For the stages of lymphedema, we are managing the third stage with the formation of fibrosis. There are a lot of evidence that there is excess subcutaneous adiposity in this situation. For this problem, no medical or surgical cure exists. It is a treatable, non-curable. What are the goals of therapy, medical or surgical? It is a reduction of volume and reduction of associated complication and improvement of limb function and appearance. If the medical failed, we are going to surgery. One indication of surgery is impaired extremity function or gross extremity size and weight, recurrent lymphangitis, and severe skin changes in form of lymphangiosarcoma. These are physiological operations, but these therapies work well when the excess swelling consists of accumulated lymph, but don't work when the excess volume is fat and fibrous tissue. We can see the size of these two shoes and the patient with different sizes of the foot. And he asks, should I put two shoes size? And if that, the larger one, it is a problem, cosmetic and psychological problem. So for many people, conservative therapy doesn't meet their expectation, and no matter what therapy they receive, neither conservative nor microsurgery procedure can remove this excess tissue. So we are going to debulking, and liposuction is a minimal subcutaneous debulking procedure. But we have problems. In comparison to abdominal liposuction, the foot has a rich venous network in the skin and dorsum of the foot. If you are going, how can you avoid this in lymphedema? After fibrosuction, we had fear of skin necrosis. Other postoperative sequelae, such as numbness, which will resolve in 6 months, and lifelong compression. We thought about solving this problem. If we can see here, the limb and swollen foot. If we want to go with liposuction cannula, we want to see the veins. So we are using AcuVein. It is called now augmented reality. I cannot see by my eyes, but I am using this infrared laser. You can see the veins here and here. And there is the duplex also. Then I want to go with the cannula. I need a port. I don't have a port, so I am using insulin syringe, cut it and fix it to the skin in these areas. What about the cannula? It is not a cannula for fat, but it is a cannula with sharp edge to cut fibrous tissue. And we are going with the site which is cutting the tissue upward, not downward, to avoid injury to the vessel. You can see here This is adapter to make infiltration anesthesia, not stopcock. Another addition. So our surgical technique, with technique, excess hypertrophied subcutaneous tissue is removed under bloodless field cannula, and the diameter of the cannula is between 3 and 5 millimeters. Here is a demonstration of some cases. It is large, and at the end of the operation, you can see you can pinch the skin. Before the operation, you cannot pinch the skin, and here is the result. You don't see this hump of the foot. Another case, and you can see here pinching also. This is a case of lymphedema localized, and it is congenital. After compression, we cannot do more than this. You can see the size, 10 centimeter by 10 centimeter. And here MRI, visualization of the vein by IQ vein. And here is the duplex. We are using duplex to make liposuction under control to avoid injury of the vessel and to measure the distances. You can see here collapse of the skin and reduction of the size. Another case, and here the thickness from about 3 centimeter to only 1 centimeter, the distance. Here is the final result after 1 week from the operation, and another cases. Here is the result after about 3 months. You can see before operation, during operation, and final result. So if we can say I had made this fibrosuction, we need a measure. You can see here the measurement, and here is the end, not only clinical. So to conclude, after conservative regimen, until minimal or no pitting edema is seen, if there is still a significant excess food volume, this can be removed by the use of fibrosuction. I cannot say it is liposuction or fibroliposuction, but continuous wearing of compression garment prevents recurrence. Thank you.
Thank you very much. I apologize because my presentation will be very provocative, let's say, but I think we can share some discussion later. This is my disclosure slide. So, why should we change, as I wrote in the title? This is an article that I wrote for the Journal of Clinical Medicine, but basically I started from a few, let's say, issues. You see here that probably science should be considered a constantly changing base of knowledge. Starting from this very simple statement, we know that when we deal with chronic venous and lymphatic diseases, we have somehow a limited knowledge of a lot of pathophysiology issues, and most treatments may have suboptimal outcomes, especially in the long term. As you can see, this is the article I told you about, but more recently, I'm trying to expand the horizons of phlebology and lymphology to improve my personal outcomes, but I think every doctor could improve the outcomes through different approaches. For example, translational medicine, this interdisciplinary merging of different experiences and culture could help us to improve the outcomes for our patients. And more than this, we know that epigenetics is entering more and more medicine. What is epigenetics? Basically, it is the science of phenotype. So as we are, with changes as to several factors which interact with our genome. So to make it short, we know that 75% of our health and disease depends upon our nutrition, lifestyle, environment, and stress management. And this is true also for chronic venous and lymphatic disease. That's why we should take into account. These are just a few cofactors which may deteriorate chronic venous and lymphatic disease through epigenetic mechanism. And probably if we keep in mind all this stuff, and as we will see, for example, obesity and overweight is one of the most important, we could surely improve the outcomes of phlebology and lymphology. That's the meaning of changing. These are examples of articles that we have written concerning these new elements we could introduce in venous and lymphatic patients management. And this is an example I showed this morning. When we treat a patient, we should keep in mind that we do not treat a leg, we treat a patient. That's why including more treatments, more diagnostic approaches could help to get a better outcome. And the Egyptians knew it very well because the Egyptians wrote long time ago that a quarter of what you eat keeps you alive. Your doctor lives with the other three quarters. That's why we should improve our nutrition, as the Egyptians wrote a long time ago. So let's move on. I want to move some critics to what we mean for medical progress and cost effectiveness, because whatever is progress should account for a combination of outcomes and an adequate, possibly better cost effectiveness profile, because we probably forget too often the relevance of cost efficacy of our advancements. And if you look at literature, you can incredibly find a lot of articles of very high level where they demonstrate that, just for example, not only most research findings are false, and this is Ioannidis, probably one of the most important scientists in the world from Stanford University. But if you look at this study, 50% of the treatments that we perform in biomedicine, have no effectiveness. And you can see that even can be unlikely beneficial and so on and so on. So a critical review of what we are doing also in phlebology and lymphology could be interesting. And these are other articles where clearly we see how the scientific investigations and scientific research may be corrupted somehow. So let's go now to phlebology and lymphology. We know that chronic venous disease is a real burden for our population and for the national health system, and that's the same for lymphatic disease. So cost effectiveness in the future will become more and more important, and pharmacoeconomic studies will become more important because of the costs that we are affording, and in this world of necessity of revision of our costs, I think we should more and more let's say, take into account this issue. More than this, we should take into account the quality of life of our patients when we treat them. Not just, for example, the occlusion rate of a vein, but the quality of life of the patients. In fact, our population is aging, and this means that we are getting more and more expenses for chronic diseases in elderly patients. That's why we should involve our patients more, asking to improve their nutrition, their exercising, their lifestyles, and so on and so on. And also the health professionals should improve as well their knowledge and their necessity to critically revise what is proposed as a medical progress. And last but not least, we see that we have a kind of accelerated obsolescence of several innovative proposals. I mean, 10 years ago or 20 years ago, we were told that SEPS was the future for perforating, and now we have abandoned SEPS, and so on, and so on, and so on. New treatments become obsolete in 10 to 20 years, but in the meanwhile, we have spent a lot of money. Let's talk about varicose vein disease. On one side, we know that we should spare a lot of veins because when dealing with the duplex, we can assess a lot of competent segments which would not need any treatment. Now we cook or stick the majority of the veins without taking into account the morphology and hemodynamics of our patients on one side, and especially our decisions are often based on reimbursement, and this is not very ethical, let's say. Last but not least, also in this field, we know that we have the issue of the long-term high recurrence rate, whatever the treatment of varicose veins. Why? Because if we look at clear-cut evidence, we know that the inter-procedure difference of saphenous occlusion at midterm, even more at long term, is very little, because each procedure, whatever the procedure you do, probably at 5 years or at 10 years, you get some 30 to 35, 40% recurrence rate in varicose vein treatment. That means that we are not doing a good job, probably. For example, you can see here for laser, it was demonstrated 58% recurrence rate at 10 years, and so on and so on. So probably we should revise the way we are treating our patients, because we should make a proper cost analysis, cost effectiveness analysis before choosing, before embracing new technologies. And let's keep in mind that retreatment is an integral part for therapy of varicose veins. That's why, for example, sclerotherapy could be an option, because we are talking about a very inexpensive treatment such as phlebectomy and so on and so on. But again, whatever the treatment, the patient-reported outcomes are very similar. So this is something to keep in mind in varicose vein treatment. And when we talk about safety of our treatments for varicose veins, you can see here O'Donnell, who is a giant in phlebology, published a very interesting review where he demonstrated clearly that there may be some differences between innovative techniques, which bring also a higher rate of complications, and let's call them minor techniques such as sclerotherapy and so on and so on. So now we talk about minor varicosities, telangiectasia and reticular varices. Primum non nocere, I was telling this morning, it means we are talking about cosmetic issues. That's why whatever the treatment, we should keep in mind not to create any harm to the patient. Sclerotherapy has been long validated as the gold standard, and any new technology such as the CLACS and such as other new technologies should anyway keep in mind primum non nocere and cost effectiveness analysis once again, because at the end of the day, the very little data we have confirm us that the mid-term or short-term outcomes are very similar for sclerotherapy and for any other treatment. The difference is in the cost, which is dramatically lower when we treat with sclerotherapy. talking about deep venous thrombosis, we have a lot of possibilities, but still we have compression and anticoagulants. That's why, for example, pharmacomechanical thrombolysis anyway increases of $222,000 per QALY, the cost of the treatment. That's why, again, we should rethink about when properly using this kind of treatment. And again, which are the long-term outcomes? Because we should not assess the treatment at 1 year or 2 years, because the patient has a long life, let's say, treatment disease. So again, it is debatable. In post-thrombotic syndrome, for example, we can use venoplasty, stenting, and so on. We can get probably a better iliac vein recanalization. But what about the patient? Is he improving his quality of life? Is he improving his post-thrombotic syndrome? So these are all elements that we should keep in mind, not just being happy with the 1 year result or 2 year results and recanalization of a vein, which is just a part of the final outcomes. And never forget about the real role of compression in post-thrombotic syndrome. And let's forget about the SOX trial. I don't want to go into details, but you know probably that this was a fundamental let's say, flowing study which destroyed compression in post-thrombotic syndrome. But if you go through the study, you can find a lot of flows, and I don't want to go into detail again, but it was a real suboptimal methodology which gave suboptimal results. Leg venous ulcer, again, compression is the cornerstone, as we know from ancient Egypt, again. But we have to keep in mind many other factors, obesity, the pump, and so on and so on. So just using let's say, compression, we can heal about 80% of leg venous ulcer within 6 months. And if you treat also varicose veins, you have an additional benefit. Regardless of all this data, at least in Europe, leg venous ulcers are treated by nurses. This means they cannot probably perform any surgery or any treatment on varices, and they perform a suboptimal, if not absent compression, because they prefer medication. So when you use medication, you can get recurrence rate of up to 70% without compression. These are data to keep in mind. Using simple medications is not enough. And then when you do not compress your patient, you double the cost of the treatment. So compression is a kind of mandatory issue. It's even more in the preventing approach to the wound of our lower leg. So in general, again, for leg venous ulcer, we can use skin grafting, deep venous surgery, whatever we use, as you see from Cochrane review, the leg venous ulcer healing rates, recurrent rates, quality of life, and adverse effects are best for compression treatment and superficial venous surgery. Full stop. This is something demonstrated, and this is important. Also, as I told you before, we should keep in mind the importance of the pump. We are treating a patient, we are not treating an ulcer. And if the patient doesn't walk well, if the patient has a BMI over 30, 35, these are very important elements. Even more when we deal lymphedema, as Franz Schingale clearly demonstrated. In lymphedema, we are still using quite old concepts and old treatments, and unfortunately, our results are a little bit suboptimal. But all these issues of obesity, calf pump, drugs, erroneous nutritional lifestyle factors play a dramatic role in the lymphedema patients, which is an inflammatory disease. And that's why when we look at the guidelines and we look at the evidence, we are still facing a very complicated world. This is the International Society of Lymphology. They clearly state no treatment method has really undergone a satisfactory meta-analysis, and we have uncertainty, ambiguity, flexibility, dissatisfaction. So this is a tragedy for lymphedema. This is the society, World Society for Lymphedema. They clearly say we don't know what to do. So before embarking in new costly treatments, we should think about that. That's why we should again involve the patients, involve the physicians in changing, let's say, lifestyle, nutrition, and so on, and improve both patients' awareness on their situation and also doctor. Let's move to the end. So we should improve the criteria to make appropriate treatments. For example, let's keep in mind that in the United States of America, the third leading cause of death is the doctor. We are the third leading cause of death. And so do not harm whenever you can. And 20% of the medical care was rated as unnecessary in USA. It means over-treatment, overuse. That's why Passman, who is an elegant guy from US, wrote a fantastic article a long time ago, I mean 2 years ago probably, and he spoke about inappropriate treatments, spoke about over-treatment, overuse, necessity of reassessment of the American way to treat chronic venous disease and lymphatic disease. This was a very honest and humble statement. So we talk about flows of patients, flows of health professionals, flows of industries, and flows of politicians. This is what we are facing because patients prefer pills and technology to the due changes in lifestyle, nutrition, and psychosocial condition. And physicians love to prescribe drugs and technology and use technology instead of working on the patients. That's why now the new movement, choosing wisely. This is something new which is spreading worldwide to choose wisely the proper diagnostic and therapeutic treatment, therapeutic means. So which are the messages to take home after this provocative presentation? We should improve our patient-centered vision when treating one patient and not one leg and not one weight, going to the basic pathophysiology of the disease. Of course, we can use drugs, we can use technologies, but we should involve the patient changing nutrition, lifestyle, and the rest that we know. And even more, cost effectiveness, appropriateness of our way of working should undergo a continuous reappraisal and revision because we should pay much more attention to biases, flows, and industry influence, especially in scientific research. Thank you very much.